First of all, I would like to thank ESR, Nilesh Bhai, Pankaj Bhai, and all the organizing committee for inviting me for this event. And it is great to see full house on Sunday morning for this diabetes update. So as Harsh has rightly mentioned, that diabetes in pregnancy is very important topic, and it is a metabolic stress which is conferring the metabolic risk to both mother as well as the child. In the recent past, what we are seeing is there is a huge epidemiological shift which is happening. The patient profile of women who are presented with diabetes in pregnancy is changing in past few decades. There is an increasing prevalence of both pre-existing diabetes as well as the gestational diabetes. The reason being there is a lower age of type 2 diabetic onset. Therefore, many women who are in a reproductive age group, they already having type 2 diabetes because of the younger age of onset of type 2 diabetes, as well as because of the higher age of conception, as well as the higher BMI of conception because of urbanization, professional lives, as well as the very good fertility treatments which are available. We see many patients who are becoming pregnant at a higher BMI as well as at a higher age, and these all are the risk factor for development of diabetes during pregnancy. If we see the phenotypic presentation, there is two phenotypes which we see for diabetes in pregnancy. One is obese, overweight with signs of insulin resistance, higher BMI, and the main reason for developing diabetes in pregnancy in this kind of patients is insulin resistance. As well as we are seeing patients who are having a lean phenotype or a normal BMI, and they have particularly postprandial spikes, and the main reason for developing diabetes in pregnancy in this kind of patient is actually beta cell dysfunction or the insulin deficiency which is there. And we see the overlap of this kind of patient also who are having both the defects, insulin resistance as well as the insulin deficiency. And why it is important to manage this hyperglycemia in the pregnancy, because there are multiple risks which are associated with hyperglycemia during pregnancy. There are maternal complications, there is risk of abortion because of the poor glycemic control and the placental vasculopathy, the risk of infection, preeclampsia increases with the presence of diabetes, postpartum bleeding, requirement of cesarean section, all these complications in a maternal side which we see. Also, there are long-term effects also. The long-term risk of development of type 2 diabetes as well as the cardiovascular risk increases over a period of time, as well as those patients who are having pre-existing diabetes, having microvascular complication with the pregnancy, there is acute increase in the progression of this microvascular complication in the mother. Also, there are fetal complications, the congenital anomalies, neural tube defects, cardiovascular malformation, macrosomia, traumatic delivery, postnatal hypoglycemia, hypocalcemia. All these are the complications which are associated with hyperglycemia, uncontrolled hyperglycemia during the pregnancy. Very important to note, there is no safe threshold for hyperglycemia because the risk is continuous. As soon as the blood sugar starts rising from the normal physiology, the risk associated with hyperglycemia increases, and there is a continuous risk. And apart from this short-term risk, we also need to focus on a long-term risk on both mother as well as the child health. In a mother, there is increased risk of future type 2 diabetes almost 7 to 10-fold. And in the child also, there is a risk of obesity, metabolic risk, as well as some cognitive impairment and autistic disorders have been found in children also. So overall, if we classify the diabetes in pregnancy, either patient might be having pre-existing diabetes or patient is developing gestational diabetes. Again, there is a huge amount of patients who are having undiagnosed pre-existing diabetes. Those patients who are not knowing that they have been diabetic, they become pregnant, and during the first antenatal visit, they found that they are diabetic. And it is very important, this pre-existing diabetes, because in this pre-existing diabetes, patient has to spend a lot of time, the whole pregnancy has to spend in a hyperglycemia, as compared to gestational diabetes, which develops after 24 to 28 weeks of gestation. And therefore, the preconception period is very important. It is a critical window for preconceptional counseling. The important organogenesis in the fetal happens during the week 3 to week 8, and therefore, Many patients who are having pre-existing diabetes, even before they come to the antenatal visit or the medical care, uh, majority of harm which is going to happen in terms of organogenesis is already happened. And therefore, it is very much specific. The protocols has to be designed to manage all these conditions for pre-existing diabetes who are undiagnosed. So any woman who are in a reproductive age group with high risk factors should be screened for diabetes. If not screened in a preconception period, as soon as patient become pregnant in the first antenatal visit, patient should be screened for diabetes. We need to identify high risk individuals, those patients who are having past history of PCOD, strong family history, obesity, signs of insulin resistance. Those patients should be screened, and the screening should be done with fasting as well as the HbA1c. For pre-existing diabetes who are diagnosed, known case of diabetes, who want to become pregnant, the diabetes can be of any type, type 1, type 2, other form of diabetes also, even a pancreatic diabetes. Whenever these kind of patients who are already diabetic, they want to become pregnant, we need to optimize the diabetes control beforehand. The HbA1c level should be less than 6.5 prior to conception. And if HbA1c levels are more than 10%, the pregnancy should be discouraged, because it is this high level of hyperglycemia can affect bad clinical outcome. Patient should be advised to use contraception till the good glycemic control is achieved. Patient should be educated regarding the unplanned pregnancy as well as the risk of fetal malformation. And there are also some medication adjustments are required in patients who are already diabetic and want to become pregnant. For gestational diabetes, we need to identify high-risk women. There are some non-modifiable factors like age, past history of gestational diabetes, family history, history of PCOD. These are non-modifiable factors. However, there are some modifiable factors like preconception weight as well as the gestational weight gain, which can be controlled with lifestyle modification to prevent the development of gestational diabetes in high-risk patients. We need to also focus on preconceptional medication. If patient is diabetic and using some or other kind of medication, that needs to be switched as soon as patient become pregnant, or even before pregnancy. ACE inhibitor, ARB, statin should be stopped. They should be switched to the pregnancy-safe antihypertensive agents. Regarding anti-diabetic agents, there should be a washout period for GLP-1 analog. They are long-acting molecules. Many women who are obese, having PCOD, diabetic, they are using these molecules, and it is very difficult. Sometimes patient, just by losing weight, they become pregnant, their fertility improves, and therefore it is very important when patient is on GLP-1 analog or dual agonist, they should be advised to use contraception, as well as whenever they plan to become pregnant, at least 1 month before planned pregnancy, the GLP-1 analog should be stopped. Regarding SGLT2 inhibitor, DPP4 inhibitor, and other oral anti-diabetic agents, they should be continued. As soon as patient become pregnant, they should be stopped. The folic acid supplementation is very important. At least 400 microgram per day should be started at least 3 months prior to the planned conception. Screening of microvascular complication is also very important. Those patients who are planning to become pregnant, pregnancy can acutely worsen pre-existing vascular complications, and therefore screening for all these microvascular complications is very important. Retinopathy, there is early worsening of retinopathy during pregnancy with intensive glycemic control which required during pregnancy might worsen retinopathy. Nephropathy should be checked with UACR and serum creatinine. There is high risk of renal dysfunction progression, as well as the risk of preeclampsia increases with the presence of nephropathy. And similar way, the neuropathy, there is erratic glucose absorption and gastroparesis, which may worsen the hyperemesis during the pregnancy. Now coming to the gestational period. The diagnostic criteria for gestational diabetes mellitus, there are different kind of strategies has been used. There is one-step strategy in which 75 gram glucose OGTT, and the criteria, the cutoffs are fasting 92, more than 92, 1 hour more than 180, and 2 hour more than 153. And there is a different strategy, that is a two-step strategy in which the criteria are little bit more relaxed, because in which when the confirmatory test has been done, they do 3 hour OGTT, and 2 out of 4 values should be out of range to diagnose gestational diabetes. And why this there is a conflict between one step and two step, because the one step strategy is try to pick up the milder cases of gestational diabetes mellitus. They try to focus on fetal programming rather than the maternal outcome. However, the two-step strategies, they are using higher threshold. They require 2 out of 4 values to out of range to diagnose gestational diabetes, and they more focus on maternal risk as well as the preventing over-treatment. And very recently published Tango DM trial in a ESD 2025 have shown that the milder cases need not to be treated. When the milder cases were subjected to standard treatment versus they were versus the intensive treatment, there is no difference in the outcomes. However, the patients who were treated with the intensive treatment, they have increased medical intervention during the trial period. The Indian guidelines, they are very straightforward. Any pregnant woman at first antenatal visit for the pre-existing diabetes, the test should be 75 gram glucose and only 2-hour post-glucose value they take. The positive test more than or equal to 140 milligram per deciliter, negative test less than 140 milligram per deciliter. If first test is negative, again we need to check at 24 to 28 weeks to diagnose gestational diabetes mellitus. Over a period of time, the clinical objectives for managing gestational diabetes has changed. In very early period in 1920s, the main target was maternal survival, because at that time, the main problem with the hyperglycemia in pregnancy with the high maternal mortality, almost 40% maternal mortality was observed during that period. Later on, with improved treatment, the main focus has shifted to the fetal survival. Preventing stillbirth was the main objective. Later on, the HAPO era comes, that is 2008, and the main focus was large for gestational babies. And now, almost we are in the era of precise optimization to prevent the fetal as well as the maternal programming of long-term health. So overall, the focus has been changed over a period of time. The current criteria for managing diabetes during pregnancy, the critical parameters are fasting sugars less than 95, 1 hour postprandial should be less than 140, and 2 hour postprandial should be less than 120 milligram per deciliter. HbA1c might not be helpful during pregnancy because of the hemodilution and the high RBC cell turnover, and therefore the HbA1c might not be very much sufficient. How we can achieve this glycemic control? The first and foremost is a lifestyle modification are the first line of therapy, and fortunately almost 70% of cases the initial glycemic control can be achieved with lifestyle modification alone in gestational diabetes patient. The nutrition, the carbohydrate, minimum carbohydrate should be 175 gram per day. The complex and low glycemic index carbohydrate, no fancy diets like keto diet or intermittent fasting should be advised during pregnancy. There should be a small and frequent meal pattern should be advised to the patient. The activity, at least 150 minutes per week of activity should be advised to the patient. It is very important. If patient walks post-meal, it helps in preventing the postprandial sugar spike. The weight gain should be according to the Obstetric Society guideline. When the BMI is lower, the recommended weight gain during pregnancy should be around 12 to 18 kg, and according to that, it should be followed. Whenever the lifestyle modifications are not sufficient, the pharmacotherapy, the insulin is the gold standard therapy because it is safe, it does not cross placenta, and it can be used in a physiological dosing. The regime should be basal bolus regime for individualized titration. Majority of insulin are in category B or category C, and that can be used very safely in a pregnant woman. The dosage in patients, how we can devise. So the initial dosage for first trimester pregnancy, 0.7 unit per kg, because there is some increased risk of hypoglycemia because of increased insulin sensitivity during that period. For second trimester, 0.8 unit per kg, and for third trimester is 0.9 to 1 unit per kg. However, these are the initial dosage for initial dose calculation. Later on, according to the finger prick sugar monitoring, we can adjust the dose as and when required. For patients who are heavily obese or having high insulin resistance, the dosage may require on a higher side. Regarding the pharmacotherapy, metformin, again, there is a huge debate regarding whether we can use metformin during pregnancy for treating this gestational diabetes or type 2 diabetes in pregnancy. So overall, if we see, the metformin crosses placenta, and whenever we are treating mother with the metformin, it also reaches to the fetal circulation also. There are definite benefit of metformin for maternal health, and they are short-term health. There is a lesser weight gain, lesser risk of hypoglycemia, high acceptance, high adherence, as well as it decreases the risk of preeclampsia. However, there are some long-term risks associated with metformin use during the pregnancy. The recent Mighty Kids data have shown there is increased risk of small for gestational age. There is a paradoxical catch-up growth, and in a offspring there is high risk of adiposity and increased BMI during the childhood. So how we can choose that in which patient we can use insulin therapy, in which patient we can use metformin therapy. So if we found a patient who is a lean GDM, BMI less than 25, the primary defect we expect is a beta cell dysfunction. In this kind of patient, insulin is the therapy of choice. The patients who are having high fasting or the early diagnosis, again, during the initial period of organogenesis, again, it is insulin should be the preferred choice. The patients who are having high BMI, insulin resistance, PCOD, needle phobia, again, in this kind of patient, metformin can be advised. However, the risk of offspring, the long-term risk to the offspring should be discussed with the patient. It is very important to see the antenatal scans and see how the fetal weight is behaving to decide whether patient would be benefited from the metformin or not. The glibenclamide, again, previously it was used, but now it is completely avoided because of the risk of macrosomia as well as the increased risk of neonatal hypoglycemia. The newer advances are the use of continuous glucose monitoring for achieving the glycemic targets. HbA1c is, as we mentioned, that it is unreliable during the pregnancy because of the RBC turnover. The pregnancy targets range are between 63 to 140, and the targets which has been suggested by the different bodies are for type 1 diabetic more than 70% time in range, and for gestational diabetes and the type 2 diabetic patient more than 90% time in range should be advised. And there is supporting data with the GRACE trial which have shown that as compared to the SMBG versus CGM, they have shown that with the CGM use there is significant reduction in large for gestational age, 3.5% versus 10.3%. Also, the automated insulin delivery system for type 1 diabetes as well as the selected type 2 diabetic, it should be advised because it can achieve the better glycemic control in the patient. It reduces the hypertensive disorder as well as the gestational weight gain. The set point should be 100 milligram per deciliter. Active insulin time should be kept at 2 hours. And the super bolus, we need to keep a aggressive carb to insulin ratio in the term of 1:3 because there is a development of insulin resistance during the gestational period. Also, obstetric surveillance and risk mitigation is required. There is the risk of preeclampsia, almost 4 times increased risk of preeclampsia with the diabetes in pregnancy. Patient should be prophylactically treated with the aspirin 150 milligram from 12 weeks of gestation. Fetal growth should be monitored, watch for large for gestational age, macrosomia as well as the small for gestational age and IUGR, and it should be measured with the abdominal circumference. Polyhydramnios, again, it is driven by the fetal polyuria, and sometimes for the lung maturity, sometimes patients who are having diabetes in pregnancy and those who are having vascular complications or uncontrolled diabetes for lung maturity, they were given antenatal steroid, and that caused significant increase in the sugar spike. We need to manage that sugar spike also, the beta-methazone induced hyperglycemia. There is a typical curve which is happening on the day 1 when the beta-methazone was given. We need to increase the dose of insulin by around 25 to 30%. The peak effect happens at the second day, in which there is 40 to 50% increase in the total daily dose of the insulin. And by the day 3 and day 4, there is a significant reduction in the hyperglycemia. And therefore, at that time, we need to again proactively reduce the dose of insulin to prevent the hypoglycemia. Regarding the intrapartum management, the delivery timing for patients who are having well-controlled gestational diabetes or type 2 diabetes, the 39 to 40 weeks of gestation should be allowed. Those patients who are having vascular complication or poor control of diabetes, elective delivery at the 36 or 37 week can be advisable. During the active labor, the target sugar should be between 70 to 110, and it should be managed with the IV insulin infusion and frequent sugar monitoring, along with the IV fluids and also we need to avoid the hypoglycemia. The placental delivery causes immediate drop in the insulin resistance, and at that point of time we need to watch for hypoglycemia. Now coming to the postpartum period, lactation. Exclusive breastfeeding for more than 3 months should be prescribed for all patients who are having diabetes during pregnancy. It reduces the risk of type 2 diabetes in both mother as well as the child. The mother risk reduced by almost 40%. The lactation increases the glucose utilization. Therefore, patients should be advised to have some snack before nursing. Management of diabetes in a lactational period. Again, for gestational diabetes, almost 70% of cases goes into remission, and we need to stop majority of insulin as well as the anti-diabetic medications which patients are on, and we need to monitor because some patients might be continue to have hyperglycemia even after delivery. For patients who are type 1 diabetes pre-existing, we need to resume 50 to 60% of pre-pregnancy dose because of significant decrease in the insulin resistance. And for type 2 diabetic patient, we can switch to pre-pregnancy orals and the insulin. However, again, here we need to focus on which medications are not secreted in the breast milk. The metformin and insulin are safe. The metformin are secreted in a very small quantities. However, the other molecules like sulfonylurea, DPP-4 inhibitor, SGLT2 inhibitor, and again the GLP-1 analog, they are not been studied very much during the lactation period, and try to avoid during lactational period as long as possible. The fourth trimester in patients who are having diabetes in pregnancy, it is a long-term health we need to focus on. The patients who are having diabetes during pregnancy, there is almost 5 to 10 times increased risk of developing type 2 diabetes in the mother, 2 times increase in the risk of cardiovascular event. And therefore, it is mandatory to check all patients who are having gestational diabetes at 6 to 12 week postpartum with the OGTT. For offspring, there is a risk of obesity and early onset type 2 diabetes. Also, there is a risk of autism spectrum disorder in the childhood, and therefore they should be monitored for that purpose also. Any individuals who are having history of gestational diabetes should have lifelong screening for the development of type 2 diabetes or pre-diabetes every 1 to 3 yearly. It is very important to keep this patient in follow-up rather than just leave them alone. So to summarize, the clinical pulse, the preconception goal should be less than 6.5. Medications which are not advisable during pregnancy should be stopped, including GLP-1 analog. Insulin is the first line therapy. Metformin can be used cautiously. Glycemic targets, fasting less than 95 and 1 hour less than 140. For comorbid condition, the blood pressure and antiplatelet should be used. The technology, we can use continuous glucose monitoring as well as automated insulin delivery system are preferred. For postpartum, we need to encourage breastfeeding, and we need to check for the persistent diabetes at 6 to 12 weeks of gestation. So the management of diabetes in pregnancy is just like marathon. It is not just about a safe delivery, but it is an opportunity to arrest the long-term progression of metabolic risk to mother and child. Thank you. Thank you for your kind attention.